Perfect. All right. Carrie, I'm going to go ahead and turn it over to you.
Alrighty, thank you so much, Allie, and thank you everyone that is attending today. My name is Dr. Carrie Mier. I am an assistant professor of criminal justice with Indiana University East. I am a trained criminologist. That is my background. So I'm kind of like a crime doctor. But my main area of interest is substance use and substance use disorders. So that's why I'm here to talk to y'all today about stigma. So as you can see, label me this, label me that, role of stigma and substance use disorders and what can be done about it. I appreciate y'all coming from both within Indiana and outside of Indiana, and I do hope that this proves to be useful for you. At the end of the presentation, I'll be providing my slides as well as some resources for things that I talk about in here. And if there's any questions you have at all, you could just type them in the chat and I'll try to get to them if I see them pop up, because they kind of pop up on my screen, but just whatever works, well, I'm good with. Alrighty, without further ado, I'm gonna start. Whoops, sorry y'all. So just to give a little bit of background, because I'm going to be talking about substance use disorders in general and sort of America's drug problem. But however, a lot of the focus that we're going to be talking about here is going to be opioid specific. So that's why I'm going to be giving some general statistics. So a lot of this will be review for many of you that work in this area and work with these issues every day. So forgive me if I'm, prattling on about something you already know all about. But as most of y'all know, the United States is experiencing an opioid epidemic that has been basically sustained since the end of the millennium, since 1999. To date, there has been over 700,000 deaths from drug overdoses, as you can see here with this CDC chart. And there's typically particular types of opioids that are driving this overdose rate, most commonly synthetic opioids such as fentanyl. And today, with the latest data available, which is 2017, it's nearly 6 times greater than what it was in 1999. And the CDC estimates that on average, 130 Americans die each day from an opioid overdose. So obviously, this is something that is quite a large problem in our country. So to kind of drive this further home, in 2017, the Council of Economic Advisors, which works with the Office of Drug Control Policy for the White House, released a statement which kind of broke down the cost of the opioid epidemic. And it said that about $504 billion was being annually spent on this. Granted, this was in 2017. We're now in 2019. So you can imagine it's probably increased. And so these numbers might be a little off, but so it goes with data, unfortunately. But as you can see here, the major costs were felt by healthcare. So that is where the largest sink goes into. Criminal justice costs, which I'll be talking about a little bit since that's a little bit more my area, especially with recidivism, which essentially means somebody is released and then they reoffend. So in the case of somebody who uses drugs, they would be arrested for another drug offense. So whether that be possession or selling or something like that, they would just be put right back into the criminal justice system. And then lastly, with business, which is something that is a very big thing felt here in Indiana, 7 out of 10 employers reported feeling hit by the lack of somebody who is not under the influence. That's something that's really big here in Richmond, where a lot of our businesses are saying they cannot find a clean workforce. So this is something that obviously is being felt. Surely those of you out of states are also feeling this as well, which of course feeds into the opioid epidemic being declared as a national emergency. The good thing about national emergency powers is that more money and federal funding can be put towards this issue. So it then moves it from being just a state's problem to now the federal government's getting involved, which kind of gives a lot more options to deal with it. But as you will see throughout this presentation, sometimes that's not enough. So here's the big reason why we really need to do something and why we really need to make sure we're tackling stigma. So old estimates stated that about 1 in 10 Americans, so about 10%, would suffer from a substance use disorder at some point in their lives. So this could be anywhere from young teen all the way up until your 60s, 70s, 80s. At any point in your life, 1 in 10 Americans are suffering from a substance use disorder or a SUD. New figures, however, now have this estimate much lower. They're now saying about 1 in 7 Americans will experience a substance use disorder. And this is primarily being driven by opioids. Because as you saw from the earlier statistics from the CDC, it's quite prevalent. But the very damaging part here is that only about 1 in 10 seek treatment. And a lot of this is due to stigma, which I will be discussing more in depth. Alcohol is a little better. We have about 1 in 3, but still only about 33% are seeking help for alcoholism versus general substance issues. So here's the biggest issue here, is that stigma kind of acts as this great barrier to getting those in treatment and towards keeping the recovery of those that have been through treatment. It can especially push people to delay it, to say, well, I'm not bad enough. Treatment is only for those that are truly damaged, and I'm not that bad. I just have a little bit of an issue, but nothing too terrible. They'll never seek it. You know, they don't want that burden on them. They just won't go get it. Or as in the research that I've done with some of my colleagues, we found that individuals with a SUD essentially recognized that they had issues and recognized that they had problems as a result of their substance use disorder, yet they did not view it as having a problem. They basically said, yes, this is negatively impacting my life, but I'm not going to do anything about it. Like, it's fine. I'm good. I can move on. And as we can see there, that kind of bleeds into the 1 in 10. So these are things that we need to address if we want to treat individuals and if we want to ultimately prevent overdoses. So here, this is where you're going to be getting into the meat of my presentation. I'll be talking about stigma in general, the various layers and levels that it works through, the overall impact of stigma, and then I will be lastly giving you all some kind of tools for what we can do as individuals, as communities, and hopefully as a society. So hopefully this will prove helpful for y'all. So to kind of start off, what is stigma? So stigma is basically the dehumanization of somebody based on their social identity or participation in a negative or undesirable social category. So you're essentially tagging them or marking them through, it could be through various things, such as an actual physical deformity, or as Matthews and his colleagues show, through a blemish of a social character, through group affiliation. It then becomes an attribute of who that person is, which addiction is very much like this. It's looked at as, if you're addicted to something, there must be something wrong with you. Like, you're a bad person. How dare you do this? Like, how dare you let yourself become an addict? This is kind of how our society views it. And when it's looked at as being detrimental, which addiction is, then society begins to associate these individuals as being bad, as being undesirable, and as being those people that we don't want to deal with. So then the person morphs into the label. And this is kind of how stigma latches itself onto people. So it can work on various levels. Obviously, the biggest one is public stigma. So public stigma is essentially society creates it and condones it. It's something that is out there that you could just walk down the street, run into someone, and they would give you their opinion of an addict, and they would not care. That is what public stigma is. In fact, I was at a restaurant in Richmond the other day, and there was a gentleman there that moved from out of state, and he was talking about the needle exchange program in Richmond, and how, oh, it's terrible because you're just encouraging those people, and they're terrible. You need to get them out of your town and tell them to move the hell on. So this is public stigma right there, because it's something that is condoned and supported, and people have very strong views of substance use and addiction. Obviously, the criminal justice system amplifies this. So people end up almost getting multiple stigmas on them, not only as having a substance use disorder, but also being involved in the criminal justice system and having a record. So it, again, creates this additional label that's attached to somebody as being dangerous or being bad or being a criminal, mostly because a lot of drug use is illegal. There's only a couple legal drugs that we have, which technically prescription drugs are legal. They're just misused. So there is like a different viewpoint to prescription drug use versus marijuana or versus methamphetamine or versus heroin. So this is where we get like different viewpoints based on drugs. The medical system can also label people when they start thinking about what they're there for. So they could label individuals as drug seeking or as non-compliant with treatment. And this can further diminish an individual wanting to seek treatment or wanting to get help. It is important to note that the ADA protects those that have been diagnosed with substance use disorders from discrimination, but it does not protect those that are currently suffering or that have been undiagnosed. So this is where it gets a little rocky, because there is some protection out there, but not a whole lot. Now, perceived stigma is where an individual has either experienced this in the past or they're anticipating experiencing it in the future, or how they think others will view them. So this like kind of interacts with the realities that we construct for ourselves and how we feel that others will interact towards us. It can be very damaging. You know, think about how you view yourself through others. This is kind of what this perceived stigma is. And if you already think that others around you are going to dismiss you, treat you bad, you know, avoid you, you know, you're going to move back, which is where these avoidance and deception, those are very common coping strategies with stigma, because you're going to just avoid telling people that you have a substance use disorder or that you've struggled with substance issues, and you might lie about it and say, no, I don't have a problem. Can I have the job now? You know, because of course, if you come out and say, yes, I have struggled with alcohol before, that's going to change how an employer looks at you versus if you don't say that. So this is where it can threaten things like security and being willing to reach out, because if you think someone's just going to dismiss you, that's how it works. And then lastly, there is the self-stigma, which is where these people kind of will then internalize the feelings of stigma and turn that guilt and shame and rejection into sort of a spoiled identity. The identity of, well, I'm just an addict, I'm just a junkie, or no one's gonna love me, no one's gonna care about me, so why not keep using? The only thing that loves me is heroin. The only thing that loves me is alcohol. It's there for me, no one else is. So this can kind of reinforce addictive behavior, and the person can just keep spiraling down and down and down, especially if they don't have that support network. So this is kind of based on the looking glass self, where we kind of internalize what society tells us, what we view of ourselves, and how we see ourselves. So stigma can come from a lot of different places, as you've seen. It can come from your friends, come from your family, come from your employers, come from the TV. It can come from a whole bunch of different things. Recovery communities, treatment communities, a lot of these things can show and help us define what it means to have a substance use disorder, what it means to be clean, what it means to be recovering, what it means to be in relapse. So all of these things like frame how people think about themselves and whether they think of themselves as successes or failures. So here's an illustration kind of how stigma will work on a more general level. So this was a really interesting study that looked at general public knowledge of opioids, stigmas, perceived treatment effectiveness, attitudes towards MAT. It kind of looked at all this sort of stuff. And what this researcher found was that most people thought that employers should be allowed to deny employment to those addicted to prescription opioids, that those addicted to prescription opioids were more dangerous, and that those that became addicted lacked self-discipline, and that was why they became addicted. Additionally, only 20% said they'd be comfortable working with someone who had an addiction to prescription opioids. So right there, you can see how that stigma, they're already thinking about how trustworthy this person is, how dedicated this person is, that they should be allowed to be denied treatment. They should be allowed to be denied employment because of who they are and because of what's happened to them. Among treatment, MAT was one of the lowest rated treatment methods for success. Many viewed it as substituting one addiction for another, and they didn't understand how it worked. They didn't understand the mechanisms of how MAT helps treat opioid addiction. So that's kind of what we're dealing with when stigma will manifest itself based on public attitudes, based on public sentiment. And you can see how this right here, denying employment, denying prescriptions, that is powerful. Because if you're going to be told, well, doctor's not going to see you, I mean, what if you're really in pain? What if you're really sick? And then what's going to happen? You're going to close it up. So this is how stigma works to close, cut off, and limit. And this is what we need to try to tackle. So here's kind of like the why should you care? So this is the why should we care words and consequences edition. So 75% of substance users report experiencing stigma from external sources, specifically due to their substance use. So they admit to experiencing these problems. Stigma has been linked to mental health issues, psychological distress, and decreased overall well-being. So these are things like suicide, depression, anxiety, so all the bad distressors that we don't want. Personal impacts relate to things such as delaying medical treatment, loss of family ties and friendships, just plain communication difficulties. Because as I said before, if you can't talk to someone, if you don't feel you could even talk to someone without the fear and risk of losing your job, you're not going to. So then you just bottle it up inside. So the stigma then becomes a label of the person, and then reactions are based on that label. Like if someone's like, so you're an addict. Oh, well, I didn't realize that. Or, oh, you're an alcoholic then. Those things can become the person. So instead of being a person with an alcohol problem, you're now an alcoholic. And that can change how we view people. That can change how we treat them. And this is where words really matter. So as I'm going to show you a little exercise here. So Broyles and colleagues wrote an editorial for their journal, which is Substance Abuse. And they talked about exploring language and how even well-intentioned words within the recovery community and within the treatment community can kind of have a really damaging impact. So they vowed to use person-first language, focus on the medical nature of substance use disorders, promote recovery, and then avoid those negative stereotypes. So I want you guys to kind of think about the following words, such as addict, junkie, habit. You know, they have a very negative connotation to them. Like, oh, you're just a junkie. Oh, that's a bad habit. You know, it kind of really gives like a negative sense of self to the person versus words like recovery, right? You're recovering from this. You're getting better from this. Substance use disorder focuses on the medical nature of substance use issues. And then medically assisted treatment, where we're looking at the treatment of this issue and not focusing on the personal character of somebody. So even words, as this journal pointed out, our name of our journal is pretty problematic, because when you hear the word abuse, well, man, most of us don't like the word abuse. It sounds bad. It sounds horrible, you know. You think violence and terrible things. So saying something like substance abuse, even though the DSM-IV describes substance abuse and substance dependence separately, it could have a very negative connotation. Addiction's the same way, even though addiction is one of those terms that tends to be more medically accepted. It could still have a very negative connotation, especially when you break it down to addict. And even a word like clean can have unintended consequences, because what's the opposite of clean? Dirty. So if somebody's not clean, they're dirty. So even there, even though we're trying to be uplifting and supporting, we could still have a negative impact here. But like anything, context matters. And this is what I'm going to be kind of talking about when we talk about words, when we talk about treatment, when we talk about all the things that people do. Context really matters here, because obviously we're all human. To err is human. And even with best intentions, we're probably going to slip up and say something we shouldn't say. So it's not like you should be kicking yourself by saying, oh man, at our recovery group, we do clean time. Well, that's great. You know, clean time is a celebration. You know, clean time is not a, well, you're not clean. You know, it's nothing like that. It's not like you're looking down on that person. It's a celebration of what they've done. So here, context matters. And it depends on the people that come to your group. If they embrace clean time, you're doing it right. So don't get too caught up in this, but it is something that is very interesting. And one of the resources I'm going to provide to Allie at the end is going to kind of talk about the words of addiction treatment and recovery, so that you all can kind of see how it's broken down. So again, why should we care? Barrier to treatment. Stigma is like one of the biggest barriers to treatment, because it kind of keeps people from seeking treatment in the first place. Because if they think they're just going to be treated badly, or they're just going to be pushed aside, or, oh, well, you're just an addict, they're not going to go. And this is extremely important because it can determine retention. You know, a treatment program works if someone goes through the whole program. It doesn't work if someone goes and stays for a day and then leaves. You know, if it's a 30-day program, we want the individual to stay for 30 days. If it's a regimen of, medication that they need to take, we want to make sure they take the whole medication, not just give up after a day, because then that'll ultimately determine success. So we want the best result we can possibly get. And those with substance use disorders report being openly discriminated against by those in healthcare, particularly through the issue of drug seeking. Many reported in this study with Leoma and colleagues, they reported just being looked at as drug seekers, where a medical professional would automatically dismiss them and say, well, we don't have narcotics. We don't give out narcotics. Which, of course, if you're legitimately sick, that's going to be a huge turnoff. And then you're not going to want to go and seek treatment. And it kind of cuts under getting treatment to those who need it the most. So this is where we need to really work on how we approach these issues, how we view individuals, and how we move forward to try to address this. So self-stigma, this is kind of where I was talking about with like something like clean time. So self-stigma is often seen in like support groups as a powerful tool to help motivate people. Because if you feel bad, if you feel guilty, those are very powerful motivating factors for getting better. Like obviously step 4 is taking a moral inventory of everything you've done. Whew, like you can't imagine something that's more shame and guilt filled, but it can help push people forward if it's used properly. Addiction narratives will often discuss things like hitting rock bottom, the bad times, or loss of control of their being, as a way that they have said, nope, I am going to push through this, I am going to get better, and I am going to be a better individual. I am going to be in recovery. And even here, using the word sobriety, it's not like sobriety is a bad word, because that's what it is. It's sober is sober. That's what it is. But for some people, it can be kind of stigmatizing. And actually, when I was like looking up information for this, there is a term now called wellbriety, which is kind of focused more on wellness and health over just being sober, over just being not using drugs and alcohol. So they're trying to push towards this embrace of wellness rather than an embrace of soberness. But as I said here, this is where context really matters, because there's a really thin line between having a positive sense of self that is fostered in recovery versus that negative past that can kind of act to pull someone down. So if you have good social supports, which I have here as some of my research says, good social supports help those stay away from behaviors that are very detrimental, like crime. It can keep people out of those behaviors. Having good social supports, having those bonds, that stuff can really help. So if somebody feels very entrenched in their support group and they feel like they can turn to their sponsor, they feel like they can turn to others in the support group, if they feel like what really is shared here stays here, and there's that trust, that's going to make a world of difference versus if they don't feel that. And those that perceive high rates of stigma are less likely to have the confidence to be in recovery. They're less likely to seek out that treatment in the first place. So this is where we really want to make sure we're fostering treatment, that we're really making sure we're fostering people's abilities to self-regulate. So as we were talking about here with opioids, stigma can become attached to certain types of treatment, like medically assisted treatment. So things like, methadone, bupe, Vivitrol, those sorts of things can kind of get a stigma attached to them. And despite their success, some individuals who use them are not viewed as really being clean or sober. They're viewed as still using, even though somebody using methadone is no longer using heroin, which we would kind of consider to be the lesser of two evils, using methadone. But the treatment itself can then become the stigma. So then this is where, in order to get, we need to move beyond this, and this is where the policies we get come from it. So we tend to be less supportive. We tend to say we need to be restrictive, like get those people out of our town sort of mentality. As I told you guys, I encountered here in Richmond just a couple weeks ago. So when we have the stigmatizing view, we're not being open, we're not being available to those around us. So again here, this is kind of the last of why we should care. So as if y'all didn't think stigma was already difficult, often stigma layers itself upon layers with other issues that people have. These can be things like dual diagnosis. So somebody who has a comorbid mental health issue with substance use disorder. So somebody that has major depression with opioid addiction. Somebody that has anxiety issues, general anxiety disorder with with heroin use. So we have a lot of those things that occur. So not only are they getting the stigma from being a user of drugs, but they're also getting the stigma from having a mental health issue. So it's like doubled up. Another dual diagnosis can be with medical issues, or like something like HIV, AIDS, hepatitis A or C. These things can be a very medical stigma attached to them. In criminology, we would refer to these types of behaviors of somebody having HIV, AIDS, hepatitis A or C as engaging in a high-risk lifestyle or what we would call antisocial lifestyle. So see right there, we're already kind of labeling a behavior as antisocial. Doesn't necessarily mean the person's antisocial. It's just what we've determined it to be. So right there you have the stigma of, okay, you have a disease and you have another disease. You have two of them beating you down. Criminal justice involvement. Obviously, as I talked about before, being criminal justice system involved is a stigma in itself, because people are going to think you're dangerous, that you're bad, that you're criminal, that if they hire you, you're going to steal from them, that if you get around them, you're going to like infect them or do something bad to them. And it just creates another layer to this issue. Being in poverty or being homeless. Many of those in the that have substance use disorders deal with these issues. Poverty is a large reason why people don't get that access to treatment that they need. Either they live in a rural area which doesn't have a lot of treatment providers, or they're homeless to where they're transient, they're like moving around, so then they don't have like a solid address, they don't have a solid way to get in touch with the treatment community or the recovery community for that matter. And then it makes it a lot harder to be in recovery at that point. So as you can see here though, we do have stigma in our society against those that are poor. We have stigma in our society against those that are homeless. If you don't think it exists, the next time you go to a large city that has a homeless population, look at how people treat the homeless. They just act like they're not even there. That's stigma. That is stigma playing out in reality. So that is what's happening. So when you have somebody that is homeless but then also has a substance use disorder, again, it's like double stigma there. And then lastly, demographics such as race and ethnicity, gender, sexual preference, and age. There can be a whole different layer to how somebody is treated based on who they are already. So a female that has a prescription drug issue could be treated much differently than a male that has a prescription drug issue. Someone who's super young, like a teenager, and versus somebody who's old. I had a conversation with a treatment practitioner the other day who told me that according to the DSM-IV, one of their clients had a cocaine addiction. And the problem is their client was 15 years old. And when they reported it, the state was like, no, they can't have an addiction. They're 15 years old. And they're like, well, according to the DSM, they do. So that's what I'm going off of. I'm going off of treatment preferences, not their age. But as you can see here, there's different types of layers that can be added on based on these assumptions. And certain things like sexual preference can keep people from reaching out because they're afraid they're going to be discriminated against for being gay, lesbian, bisexual, trans versus, just trying to seek help. So you can see how all of these layers just kind of just keep adding up. And they're all things we need to think about when we're trying to figure out what to do. Which, speaking of what to do, this is now we're turning into the what can be done. Because obviously that's what y'all want to know is, you don't want to know that it's just a huge, big, terrible, horrible problem. We want to do something about it. So obviously, starting with the individual, education and training can go a long, long way. Obviously, all of y'all here today, which there are 16 participants. Hello, everyone. All of y'all here today, you're getting educated. You're learning about this stuff. That's a great first step. And as I said before, we're all human. we're all going to make mistakes. Even those of us that have good intentions, sometimes we're going to slip up. That doesn't mean you're a bad person. That doesn't mean that you're actively engaging in stigma or that you're actively doing these horrible things. It just means you're human. So as I said before, context matters, because there's a big difference between being in a support group and asking, are you clean, versus being at the doctor's office and they're asking, are you clean? So there's a lot of difference there between those environments and whether you feel supported, safe, trustworthy, or not. So one example that I have is a service learning experience that I did here at Indiana University East. I taught an addictions class, and I had my students go out and do service learning with recovery support groups in the area, which were Brianna's Hope. So we worked with 4 different Brianna's Hopes around Wayne County, and my students had a major change in their personal attitudes about addiction, about drug use, about people who have substance issues. I mean, they just did a 180, because in their prior reflections, my students would say things like, well, I think they're bad people, I think they're dirty, I think they're gonna steal, I think they don't try, I think they're lazy. And then when they came back after the experience, they were like, wow, I can't believe like how I had that attitude. Like, I can't believe that I thought these people were bad. I can't believe that I thought they weren't trying. Like, they're definitely trying. They're working so hard, you know, and each little success just adds up. So, I mean, it was just a 180 change in my class. So, and that's just one thing that we can do, and that's something I'm doing with my students here, but I am one person. So obviously, if all of us do things to get out there and have information put out there and help people examine their knowledge of drug use and help people listen to experiences and consequences, then we can be those advocates to change stigma. So here we really need to push for shifting attitudes about acceptance, treatment, discrimination. We need to kind of change all those things, and we need to push for social support. Because if we have those social supports, that reduces a lot of other negative outcomes and other bad things that we really want to avoid. So what can be done community edition? So really, when we're looking at our communities and what we're doing in our communities, we need to look at whether it's harmful or whether it's harm reducing. So some strategies like needle exchange programs, safe injection sites, medically assisted treatment, they're very controversial, because it's like, well, you're just giving them drugs. Why would you do that for? Oh, it's why is it going to do it? However, if it's implemented correctly and if it's overseen correctly, it serves as a way of getting those that are obviously concerned about their health, because you wouldn't reuse a clean needle if you didn't care, right? So if we're trying to get those people into treatment, that's the ultimate goal. We're trying to get them into treatment, get them into recovery, and not using. So that is the ultimate goal of harm reduction policies versus our normal strategy of arrest, incarceration, rinse and repeat with recidivism. The example that I'm using here is the Help Not Handcuffs initiative, which was used by our neighboring city of Dayton, Ohio, and Montgomery County. And they actually reduced opioid deaths in their county by half, due to using harm reduction policies instead of just sending individuals to jail. So this was what their community was trying to do to address the problem, and it helped, because Montgomery County was huge in Ohio. It had a giant overdose issue, and it is a big hub for drug trafficking and fentanyl, because there are several major interstates that interact in that area. So it was something that they needed to do, and this is what they're doing to kind of get through that issue. So once we get individuals into treatment, that stigma will begin to wane, because the treatment environment itself is going to help for that. So as long as the treatment environment is open, trusting, warm, that someone can feel like what I say here stays here, then they're going to be fine. They'll be able to get into recovery. But it's just getting into that appropriate treatment environment that has those social supports there. Anti-stigma campaigns are also very, very useful here, because then they help redirect, they help redirect the conversation from substance abuse to recovery, which is very, very important for success in public health. So as you can see here, these are things that should be focuses of anti-stigma campaigns. So attacking that perception that treatment is weak, that those that go to treatment are weak individuals, and that you can't do it yourself, why not? It's like, no, there's nothing wrong with seeking treatment. It's like, if I'm sick, I go to the doctor. Why wouldn't you? It's the same thing. A perception of being dangerous or incompetent or an individual with low self-control. We want to get away from that. Having a self-blame there and saying, it's all my fault. I'm a terrible, horrible person. I'm terrible. I'm horrible. All I'm ever going to be is a junkie. All I'm ever going to be is an alcoholic. Never going to change. As I said before, context matters here, because a little bit of that can be a push towards getting in recovery and maintaining recovery. But you don't want to be weighed down with self-blame and to have so much guilt that a person can't move past it. So that's where we want to, get to that plane. Putting out there that effective treatment is available and getting it to those people that need it, because treatment is out there. There's lots of different treatments out there, but a lot of people can't get to it. Many people that I've worked with in the recovery community, they don't have transportation. So if you don't have a car, how are you going to drive across a county that's 30 miles wide to get to your treatment appointment? So this is where these things kind of become issues. Educating doctors to treat addiction. Now, this kind of seems like a no-brainer, but there was a, which I should have cited it here, sorry about that, y'all, but there was a recent New York Times article that looked at how only 10% of doctors have been trained in addiction medicine, that most doctors do not know how to adequately address addiction issues and how to appropriately talk to their patients about addiction potential when they're prescribing opioids, when they are talking somebody through treatment. They don't know those things because they haven't been trained in those things. And this is where we need to help our medical professionals help their patients. So again, it's just getting out there, getting that information out there, getting that education out there. And then lastly, enforcing non-discrimination policies so that, people can't be kept from employment, that people can't be kicked out of their homes, and that people can't be refused treatment. Because then again, if people think they're going to be kicked out onto the street, they're not going to seek help, because then they're going to be homeless. So this is where we want to make sure that we're not like being overly punitive here. And lastly, this is the society edition. What do we do? Because this is a very hard problem, because society is huge, and a lot of our societal viewpoint here in America is viewed on substance use disorders being deeply stigmatizing. So again, education, learning how addiction works, learning how the addicted brain works, learning about treatment options, all of that is through becoming educated, getting the word out there, learning about things, participating in outreach. Just as I talked about with my service learning class, a lot of my students are criminal justice students. They want to be police officers. They want to go into the field. However, they've never interacted with anybody that has an addiction issue. And this is who they're going to be interacting with when they are actually law enforcement officers. So it's like, to get them out there now and to help change their perception of people is very important before they graduate and they're out there in the field. It makes it less dangerous for them, and it makes it less dangerous for the people that need help. So this is where we need to do these sorts of things to get our voices out there and reach those that really need our help. So a really cool theory of drug abuse is from Vaughan, and he talks about a cell to society approach where we need to consider all factors that play a role in addiction. We need to look at everything from genetic predispositions to negative environments to resilience to families to support groups to policy, all the way, all of those spans all matter. So if we just fix one thing, we're still going to have like 10 other things to address. So we need to kind of have this holistic viewpoint of the issue. And it's not something that can be solved with a silver bullet of like, well, if we just, educate people more, then it'll stop. It might stop for some, but it's not going to nip the issue in the bud. So that's why we need to make sure that we're working through it as much as we can. So having things like motivational interviewing, having positive stories of those that are in recovery can go a really long way towards changing the rhetoric we hear on the news every day. And the main thing to note here is that addiction stigma has remained stable over time. So what people think about alcoholism, what people think about addiction, what people think about particular types of drugs remain very stable. But being aware of this is the first step in changing it. So this kind of just requires us all to work slowly but surely towards change. And that is the end of my presentation. I greatly, greatly appreciate you all for letting me talk about this. And I will be sharing my slides with you. So then if you want the slides, you can go ahead and have that. I'll also be providing you with my resources, so then you can kind of see the citations that I've used for this. And I will be giving you I'll be providing a resource to Allie from SAMHSA that talks about the appropriate language that you should be using in recovery settings. They kind of have like a good, okay, and bad sort of languages to be used. So I'll be providing that as well because it is a really cool guide. So I'll be giving all of that to y'all. So let me get up here because I see a couple chats to bring up here.
Thanks, Carrie. While you're checking those chats out, I just want to remind everybody, I have shared my email address. If you do want copies of those slides, please reach out to Carrie or myself. We will have copies of those and the resources available for you. I've also shared the link to our post survey. Again, it is incredibly quick. If it takes you more than 60 seconds, I would be surprised. And it's very important for us in our data collection and our ability to continue having these kinds of programs. So I'll turn it back over to you now if you have any questions you want to address.
I was just going to say, I don't see anything in the chat as of yet. I was going to say I may have said everything that needed to be said. But that's absolutely okay. I also have my email address provided here, which is cworsel@iue.edu. Definitely feel free to reach out to me, talk to me about anything like this. I'm completely open. I obviously used some of my own research in here as well. So if you want to talk to me about my own research, I'm completely open to that as well. And I always like talking data and sharing with people. So no worries there.
Okay, well, we certainly appreciate your time today and your excellent presentation. Certainly very, very good information for all of us. We appreciate everyone else that came on and viewed the presentation today. We have recorded it and we'll be posting to our YouTube channel as well if you would like to view this presentation again, or if you would like to share it with somebody with whom you think it might resound, or somebody that needs it for their professional career. It's really great information for almost all walks of life. So thank you, everybody.